This is Tanya with the Sober on Purpose podcast. And earlier in June, I got to attend the SUPAR Conference, which is Substance Use Prevention and Recovery Conference. I was blown away by the collaboration and the material, and I wanted to bring it to you, our Sober on Purpose audience. So I asked your permission to do that in a series. These are going to come out relatively quickly. They're going to be followed with the suparseminar.com site, which you'll also be able to find information on the Joyous Family website. And we're going to start with one that I didn't know a whole lot about, the opioid crisis. And Rob Valuck, a PhD from the University of Colorado and a professor of clinical pharmacy, is our first speaker. He was amazing. Just the understanding and clarity with which he was able to deliver it was just something I didn't quite understand, but now I have a much better grasp on. So this talks about policy in Colorado, but it is replicatable. And if you have any idea of how many people are hooked on opioids and that 70% of them do not get them from their doctor, nor do they get them from the street, it's a very interesting conversation. So please join me.
Real life for real families. Hurts, habits, and hang-ups happen in every family.
Jerry and I are here with tools to help you trust God, clean house, and tell the truth to ramp up the joy in your family.
You have what it takes.
It's time to become sober on purpose
for His purpose.
Hello, Sober on Purpose. I am here with Rob Valuck, professor of pharmacology at the University of Colorado. We are at the SUPAR Conference in Steamboat, Colorado, which has just been amazing. And Rob just spoke this morning. His information is overwhelming. So we're going to talk a small piece of it, but I'm going to let him introduce himself because he has several titles. But he is an expert in opioids.
Hi, thanks. It's really great to be here. I'm glad to have the chance to share with you. My name's Rob Valuck. I'm a professor at CU, a pharmacy guy from a long time ago, and over the last several years have been working as the director of an organization called the Colorado Consortium for Perscription Drug Abuse Prevention. And we're a statewide task force that Governor Hickenlooper formed back in 2013 to develop a coordinated response to the opioid crisis in Colorado, because it affects every county in Colorado is affected by this. Way too many families are affected, and we decided, rightly so, that we need to do a better job coordinating our response and doing more to help fight it.
And you gave us some really interesting facts about how people get a hold of opioids and what is prescribed to households, and it's just amazing.
Yeah, it really is. I think people know that opioids are frequently prescribed, and they generally get that. But even, doctors, families, patients, but people don't realize that just within the last 4 years, this peaked about 4 years ago, in the United States, 260 million prescriptions for opioids went out. And each one of them had 55 tablets on average. So it ended up being 15 billion opioid tablets going into medicine cabinets around the country, enough for every household in America to have 2 bottles of opioid pills every year. That was the quantity going out, and it's gradually coming down. We're about 25% less than that now, but it's a staggering amount of opioids going out there. So people wonder, where do people get them? How do they get started? It's not the drug cartels where people start. It's not heroin where people start. Nobody picks up a needle and injects heroin one day for grins. No one. Not one person. But they start off with stuff. 70% of people start off with leftovers in a family member or friend's medicine cabinet. 17% start with their own leftovers from a prior prescription. 87% of people who end up in a bad way, which is addicted or overdose or unfortunately die, or if they're lucky, live and get into treatment. 87% started with all of these leftovers from all of these prescriptions.
And how many get prescribed on average, and then how many do people actually use during the time that they need them, after surgery or a break or something like that?
Yeah, it's remarkable. You see these numbers. 55 is the average for going out. Most people take anywhere from 4 to 15 tablets after anything that they're prescribed for, even if it's a bunionectomy or a wisdom tooth extraction, which is somewhat painful, all the way up to a hip replacement, which is very painful. Most people, even with a hip replacement, on average take 15 tablets or fewer, and then they're done, and can move over to things like Motrin or Tylenol and manage it with more, over-the-counter pain relievers, which people say are, less powerful. Not true. They work equally or slightly better. We've just never been told that. As, nobody was making money from opioid manufacturers aren't making money telling you that ibuprofen works better.
Well, and that was super interesting when you put that up about the efficacy of ibuprofen versus these opioids, which people are thinking, oh, these are fantastic. Yep. Explain how that works and how well ibuprofen works on its own.
Oh, no, it's a total myth that the opioids are the most powerful pain relievers. People think that to be true. It's a myth. They're controlled substances, not because they're more powerful pain relievers. They're controlled substances because they have a stronger ability to get you addicted and kill you. That's why the DEA schedules medications, like they'll say Schedule 4, Schedule 3, Schedule 2. And the smaller the number, like the Schedule 2s, people think, oh, that's the good stuff because it's Schedule 2. And I say, no, it has nothing to do with how well it relieves your pain. It's Schedule 2 because it has higher rates of death and higher rates of addiction and diversion and ruining families and ruining communities. That's why it's Schedule 2. The DEA does not evaluate how well a medication works for its therapeutic benefit. The FDA does. So DEA scheduling, people think that's the good stuff. It has nothing to do with it. If the lower the DEA number, the more I stay away from it because I don't want to die.
I don't think any of us want to die,
right.
Even the people who
get
addicted.
People don't realize that, wait a minute, that number's not an indication of something I do want. Like the Schedule 2 is better than the Schedule 3. It's the opposite. If it goes to Schedule 3, I should be scared. If it goes to Schedule 2, I should be even more scared. Okay. Not thinking that that's better for me. It's more dangerous. Well, and we don't think that way.
No, we don't. And I hope to have a chart up from your notes on, tell me about the efficacy of the ibuprofen. I mean, it was amazing.
It's been well studied. For 30 years, we've known this. Back, it's not important that I'm a really old person, but back in pharmacy school, we knew that ibuprofen on average gives you about 55% pain relief for musculoskeletal pain. Opioids give you about 33% relief of pain for musculoskeletal pain. So if you want, I've always said, I want the good stuff, but for me, good stuff means what gives me the most pain relief. Ibuprofen works better than opioids for musculoskeletal pain. It's well known. So for acute pain, you sprained your ankle, you have a post-surgical thing like a wisdom tooth,
Exactly,
you broke your hand, klutz, you fell over and broke your hand, whatever it is. For any of those kinds of things, the ibuprofen works better. And if you rotate ibuprofen and then Tylenol every 3 hours back and forth, it's slightly even better. So the best pain relief you can get, twice as good as opioids, 66% pain relief. If you rotate Tylenol and ibuprofen, which you can go down to your local supermarket, forget even drugstore, and get these stuff by the thousands for $8. It doesn't cost a lot to have ibuprofen and Tylenol in your medicine cabinet, and you're not going to have somebody get addicted or die.
What's your body risk for the ibuprofen? Because you talked about liver and things like that.
There still are. There's, like I also say as a pharmacy professor, there's no free lunch. Any medication has side effects. So you don't want to be gobbling down ibuprofen all day because you can have gastrointestinal problems. With acetaminophen, you can have liver problems or kidney problems if you take too much. So you don't want to gobble those down indiscriminately either. No matter what medication you have, you should use the smallest amount that gives you the effect you need. And you should be talking to your doctor. I mean, if you take ibuprofen for a day or two, no big deal. But if you're going to take this for months on end because you have arthritis or chronic pain, that's something conversation to have with your doctor to understand what's the right medication for you, maybe some physical therapy or some chiropractic, maybe less of this medication, and we can minimize the side effects. But any medication has side effects.
And let's switch back to how people get a hold of opioids. So it's not necessarily after surgery. It's not necessarily like that. You might get opioids then, but 70% get it from friends or family. And you told a great story about a cab driver you met. Can you share that story with us?
Oh, yeah. I was in another part of the state getting ready to do one of these talks, just like I did this morning. And I'm riding in an Uber from the airport to the hotel. And I'm talking to this driver. And he said, oh, that's interesting that you're dealing with the opioid thing. That's interesting. I said, yeah, 70% of the problem starts in the medicine cabinet. He said, well, yeah, I understand. And I said, so do you have any opioids in your medicine cabinet? He said, well, I probably do. I think I do. But I don't have anybody come to my house no one comes to my house. And I thought, really? You live by yourself off the grid and no one ever comes to your house. You don't have an electrician or you do your own plumbing and electrical work?
Yeah.
He said, well, no, I have an electrician and a plumber and a housekeeper. And I said, do you mow your own lawn? No, I have the neighbor kid mows the lawn. And I said, has he ever used your bathroom? Well, yeah, of course, he just used the bathroom and you don't have any family members or friends. So you live alone and have no friends. You seem like a nice guy, but you have no friends? He goes, oh no, I have friends and they come over for dinner. I said, well, you just described about 30 people that have access to your house and therefore have access to your medicine cabinet unless you tell me you have a safe that you put your medications in. He says, no, I don't. So he said, oh, maybe at the end of the cab ride, he said, well, maybe I should go take those opioids and either get them back at the safe disposal site or at the very least get them out of the medicine cabinet and lock them up. So that was good. It was really good. But it shows that everybody has them. It's very common. More people have them in their medicine cabinets than not. 55% of Coloradans report having them in their medicine cabinet, but don't realize that their son, daughter, friend, spouse, electrician, whoever, neighbor, could be accessing those opioids. And even if they aren't, they could. So it's a risk for all of us to have these things sitting around. And we got to get rid of them when we're done. And until we're done with them, if we're still using them, we got to lock them up.
And who would really know they were there?
Right. That's the trouble is, the people that we would least like to have them are the first to know, like our kids. I've had teenagers. Look, I've gone through this too. I understand what it's like to raise kids. And the kids know more than you do about the meds that are in your medicine cabinet. They know what has street value. They know what works for what. They know what would get them high. Kids know. And we want to keep medications out of their hands and, give them other alternatives to be doing other things, a whole other conversation, but certainly do not want to make it easy inadvertently to have an opioid supply in our own house that could be obtained by our own children. So we all have that collective responsibility to get the opioids out of our medicine cabinets when we're done with them. And while we're using them, if we're under a doctor's orders, great. Lock them up. We call it safe use, safe storage, safe disposal. And if you don't do all three of those things, we're opening doors to addiction and abuse.
And the other thing that I learned about addiction with opioids today was how quickly the addiction can happen. Can you go through the statistics on, 1 to 5 or?
Oh, absolutely. No, it's really remarkable. Your body starts adapting on the first dose. So any amount of opioid starts to put you at risk of long-term use. If you get a prescription of any kind for any amount, 6% of people are still taking them a year later, even with a few tablets. So it's still 6% of people will continue to take them, even if you only give them 4 or 5 tablets after a procedure, and which is very rational. Still 6% of people taking them a year later. If you give them a 7-day supply, 20% of people taking them a year later. When you give them just a week's worth, which doesn't sound like giving them 200 tablets, but even a smaller amount can then turn it around to 1 in 5 people taking those opioids a year later. So they're much more powerful than people think. The body starts adapting right on the first dose. And people will tell you that take them 3 or 4 weeks for something like a hip replacement or a major procedure. Boy, when I stopped my opioids, I felt like I got the flu. It was kind of bad coincidence that I got the flu. And I told them, no, it wasn't a coincidence. You didn't have the flu. You had junior varsity opioid withdrawal. And you didn't realize that after 3 weeks, on average, 17 days, people will feel withdrawal symptoms if they've been only taking them for 17 days.
It's too quick. It's too quick. Whereas if you're using the ibuprofen, which works really well, you're not going to have
withdrawal. Now, again, you don't want to gobble down the ibuprofen because you could cause a GI bleed. You could cause renal problems or liver problems, kidney problems if you take too much.
Right.
But if you use them responsibly, they're remarkably safe to just use ibuprofen, and it's, again, generic. $6 and you can buy 20,000 of these things. It's really, the cost is not an issue. Right. Everybody has jugs of those things. And that's, if you're going to have a jug of pain medication around, I would rather it be a jug of ibuprofen than an opioid.
Now, Rob, you've been doing great work on the policy level. Can you tell me more about the policy work? And you have reduced it by an enormous amount.
Well, I think we're making progress. Our legislature, the good news is they're listening. They're very engaged in this topic, and there's probably a handful of legislators, 10 or 12 of them, that are really, really dialed into this issue and have been for the last 2 or 3 years, which is awesome. It means we don't have to educate them over and over and over again and start from square zero. And so we passed several pieces of very important legislation, everything from prevention on the upstream side to help work with at-risk youth and do better prevention, to screening and brief intervention and referral to treatment called SBIRT, to harm reduction, getting more naloxone out there. It's an overdose reversing drug called naloxone. And if someone has an overdose, it will save their life. And no life has to be lost to this crisis.
And it's a nasal spray.
It's a nasal
really
spray or an
easy
injection, either way, whatever people prefer.
Right.
But there's a nasal spray, super easy. If you can squeeze your fingers together, you're trained, right? I mean, everyone knows how to use a nasal spray. And no harm to somebody can be caused by it. There's laws in Colorado that protect you if you administer naloxone to somebody that you even suspect they might have had an overdose. You're protected by immunity and can't be prosecuted for giving them the naloxone. Okay. So there's total immunity if you want to use it. Medicaid covers it with no prior authorization. So, naloxone is a key strategy for preventing overdose deaths right now, today. And then we're ramping up a lot of stuff with legislation to expand access to treatment and recovery, because obviously we have a lot of people who are in trouble and who are in need, and we need to provide services for them and not stigmatize them, because as a friend of mine says, if shame and blame and stigma had worked, we would have wrapped this thing up long ago.
About 1850, right?
Yeah, exactly. We would, exactly. Back in the Sumerian times when people stepped on grapes and started making wine, we would have solved this thing a couple thousand years ago if shame and blame worked. But it doesn't. People have use disorders. It's recognized by science and medicine as a chronic, relapsing, remitting disease of the brain. So we don't tell people with diabetes that they are too shameful to be treated. And we should not be doing that with people who have use disorders. We need to provide them medical care. And if we do, treatment works. And recovery is possible. There is reason for hope. We just have to get our act together as a medical community and as just communities of people. It's a question of humanity to treat our neighbors with the respect that they deserve, that everybody that has a use disorder is a valuable life just like anybody else. And we need to provide them treatment and not shame, blame, or incarceration because it doesn't work. And that's the thing. It's been shown over the 40 years of history. Those things don't work. What works is treatment.
And you showed some really scary death statistics as well.
Yeah, it's frightening. 74,000 people died from drug overdoses in the United States in 2017. 50,000 of them are opioid related. In Colorado, that's about 600 people last year died from opioid related overdoses. Just way too many people dying from a preventable thing that all of these overdoses, virtually all of them, are preventable if people have naloxone. If we can get them into treatment and reduce their cravings for something like heroin or whatever, and say, no, you don't have to do that. We can get you on methadone or buprenorphine or the appropriate medication-assisted treatment and get you counseling and get you job support and get you housing support and get your life back. There is a way to go from the very depths of this difficult situation to a productive, get your life back kind of situation. And we know how to do it. We just aren't doing it well enough. And that's the disappointment to me is we have the science, we have the technology, we know what to do. We're just not deploying it very well right now. And we're working very hard to try to build systems now to deliver this care better. And that's why we're here this weekend at the SUPAR seminar, is to talk with each other and figure out how do we get more people into treatment? How do we deliver the treatment better? How do we get people into sustained recovery so they can have their lives back? Because it works.
And it's highly possible. And you were able to procure, your consortium was able to procure money to run these programs, which was a quarter of the budget for this? Or how does that work?
Yeah, we advocate for all kinds of funding, right? We go to the legislature and we say we need these laws or these programs or whatever. And of course, some of our requests are for funding. And in Colorado, it's hard to get legislative funding in Colorado because we have a fixed budget and we're a TABOR-controlled state. And so there's no new money without referendum. There is no new money. The only new money coming in Colorado is from the Marijuana Tax Cash Fund. So this is the only source of new revenue in Colorado. So we shamelessly said we would like to have $50 million from the Marijuana Tax Cash Fund, which was a quarter of all of the Marijuana Tax Cash Fund last year.
Only a quarter.
Only a quarter. And we've got people lined up outside the door, which I understand, for roads and bridges and K through 12 and jails and everything else, which I understand. We have a state full of different needs. And I don't argue that those things are important, but my job is to advocate on behalf of this issue. So I do. And we asked for a little sum of $50 million. And so we got $10 million for a whole host of other programs. But the big one we got a year ago, not this year, but a year ago, was to help get funding for Medicaid to cover medical detox, inpatient treatment, and residential treatment, which is very necessary for a lot of people with more serious use disorders. Some people can move directly into outpatient treatment to start off with. A lot of people cannot without detox and inpatient and residential, and maybe all three. And if it's not covered by Medicaid, then you see problems. Like places will shut down or not even be able to open. Arapahoe House in the metro area shut down because there's no coverage for medical detox, no coverage for inpatient and residential treatment, and that's what they were offering. So 4,800 people lost services when they shut down. It's a lot of people, and that's just one provider. And so we said that's a problem. So the legislature passed a law telling Medicaid to apply for the federal benefit, but we had to come up with our state share, and the state share was $40 million. And the outgoing Governor Hickenlooper, thought long and hard about this, and I understand that because I was going to take the $40 million and give it to schools or to jails or to this particular bill for Medicaid. And I know that's a tough choice, and I didn't have to make that choice, but he made it, and thank goodness for us, he made that choice because starting in a year, we'll get the $40 million from the state and $210 million federal matching funds and be able to offer $250 million of new funding next year to expand opioid use disorder and other substance use disorder treatment in Colorado. It'll be the single biggest thing we've ever done as a state. So we're very proud of it, but it's only another piece. We have a huge treatment gap, and this will take a bite out of it, but not the whole thing. So we're working hard to cover things for Medicaid, to cover things in jails, to cover recovery services after people get out of these acute settings, like incarceration or residential or inpatient treatment, and can transition into communities and have housing and job training and continued therapy and support from peers. Because if you can give them a peer support community of new peers that are just like them, that understand what it means to have gone through this, and you don't go back to the same peer group you had before and go back to using, then we can get people successfully treated. It works. We just have to do it.
So like you said, not only do you have the science research to back it, not only do you know how to do it, now your consortium has successfully generated the money to begin to producing it for the population. As you said earlier, it's a disrespecter of whether you have money or don't have money or your socioeconomic status, but you've put it at the Medicaid level where people can get a hold of it when they need it.
Exactly.
That's just, it's fabulous. And Rob, I really want to thank you for all your hard work. I know this is not what you went into academia for.
No, it's not what I thought I was going to be doing. But I'm very pleased with how my career's evolved to be doing this. This feels like a calling to me. I'm a native Coloradan. I've been to all 64 counties in this state 3 times in my life, twice in the last 4 years, just because of this issue. And so I've seen, and met people from all over the place. And today, meeting a judge that's doing, a wonderful drug court program, or meeting people standing up new forms of recovery support, or what's going on, here in Routt County. It's meet colleagues everywhere that I go, in all 64 counties. And the problem is the same, and yet it's different, everywhere you go, because every community is a little bit different in terms of what people are doing and what the healthcare is like and public health and what the different systems are and what the culture is and what the politics are. So it's all has its uniqueness, but we're all Coloradans and everybody needs to help each other out. So we're trying to do that.
Now, is Colorado leading the way we led the way in marijuana legalization. Are we leading the way in how do we clean up for some of the things that have not been done well?
We like to think we don't want to pat ourselves on the back too hard, but we think we're leading. We're among 3 or 4 states that other organizations like the National Conference on State Legislatures, the American Medical Association singled us out among 4 states for the quality of their response. We get asked to national meetings now. There's a national conference, believe it or not, on opioid and heroin abuse. There's conferences like the past 2 presidents have spoken at this conference these last couple of years, and so it's a big deal. And we get recognized at these conferences for having a leading type of approach, a collaborative, bottom up, everybody work together kind of approach. And I said, that's really the way Coloradans are. We innovate. I think we really want to pull together as communities and work together. Yes, we have our disagreements, but I really think underneath that, we really give a darn. We really want to help each other out, that we do, even though we have split legislatures, whatever, that we have people that want to work together despite political differences and want to do the right thing for communities. And so I think we have a good example, and our legislature is working like that, which I'm very pleased to see, is that, despite all the political rhetoric and the difficulties of the times, this is an issue where people get together and say, it's not about politics, it's about people, and let's do the right thing.
Right.
So it's encouraging.
It's about keeping people alive.
Exactly.
Which is from your talk this morning, that's what I heard from you, is about keeping people alive.
Yep.
So how could people get in touch with you, whether they were policy people or learn more about your programs? Where's your .com?
Yep, absolutely. No, there's our public-facing website is for like our campaign for safe use and safe storage and safe disposal and those kinds of resources. That's called takemedsseriously.org. Or if they just want to learn about our organization, the consortium, you can find at the bottom of that page, you can click over to us, or just go to corxconsortium.org. And then you can see what we do, how we do it. All of our work is open. We have lay people, treatment professionals, law enforcement professionals, people in recovery, all sorts of folks from all over the state that participate on our work groups, basically just to share ideas, convey ideas to the legislature, just, tell us what the needs are so we can advocate for those needs. And people can join. The consortium doesn't cost you anything. You don't have to do anything. You don't have to pay anything. We just want people to join arms and say, hey, we can speak more loudly if there are 700 or 800 of us talking than 7 or 8 of us talking. And it works, and the legislature listens. So join us and look at our website and click on Get Involved, and even if it's just to get on our mailing list so you can see what's going on and chip in wherever you think.
And so this is, like you said, you had people who are in recovery in there. You had people who are working at different levels. So you're calling in all the stakeholders and saying, how do we pull this together in an integrative approach that works for Colorado, and hopefully you can expand out into the United States and maybe even further. Rob, again, I just really want to thank you for being here. Thank you for your hard work. You have really put in super amount of effort. And Sober on Purpose, folks, I am hoping to have some of his slides up on the show notes. We will get that rolling as the SUPAR Conference produces those slides for us. So again, thank you so much, Rob.
Absolutely. Thank you.
Hey, I just wanted to come on and say thanks for listening. This is, I think, a super important topic, and the SUPAR Conference brought a lot of important topics. So as I said, these are going to be a series, and I am hoping to put them out back to back to back. They will always have SUPRA in the title, so you'll know how to find them on the podcast. And I'd really enjoy your feedback. We have a private Facebook group, Sober on Purpose Facebook group, where we would enjoy your feedback on that. Or you can drop me an email at tanya@thejoyousfamily.com, or you can reach me over at Instagram at thejoyousfamily.com. So a dozen ways to reach me, but I would appreciate your feedback on whether this is something that has been valuable to you. It certainly was valuable to me, and I wanted to share it with this community. So thank you so much for listening, and we'll look forward to hearing from you.